This is where we left off the last time. So here are the answers. I know you guys have done some group work trying to figure it out, and hopefully by now you have a little bit better understanding of your concave convex rule and how all of that works. So here are the answers for that if you need them, and then if you still have further questions on this material, we can also go over it in your lab groups to do it in a little bit smaller setting where it might make a little bit more sense to you all. Okay. So for the muscles, same like we talked about last week, I am not going to go through your origin, insertion, nerve, and action for every muscle, but I expect you to know them. Okay? Make sure you're able to group them in different ways. If they have common origins, if they have common insertions, if they have common nerves, make sure you approach this material from several different ways. Okay? So here are your shoulder flexors. So this is going to include your pectoralis major, just the clavicular portion. So understand your pec major has two different portions. We have the clavicular portion, we have the sternal portion. Okay? So your clavicular portion, this flexes the shoulder up to 60 degrees. Okay, so make sure you know the degrees that's associated with that as well. Okay, anterior delt. So again, we have three portions of the deltoid. Anterior delt is the only one that's involved in shoulder flexion. Okay, biceps brachii, that's a two joint muscle, so that means it's going to have action both at the shoulder and at the elbow. Okay, and then coracobrachialis. So this, depending on when you guys took Bio 150, in the old textbook, this was just a stabilizer, and in the updated textbook, it is considered a shoulder flexor. So just, tuck that in the back of your head if you were working out of the old one at some point. This one's a little bit different. Okay, next we have your shoulder extensors. So this is your other portion of pectoralis major. The sternal portion of pec major is a shoulder extensor. It extends from 180 degrees to 120. Okay, so just that little bit, it extends the shoulder. So basically initiates shoulder extension from a flexed position. Okay, you have your latissimus dorsi, posterior delt. Again, you have those three components of the deltoid. Posterior delt is the only one involved in shoulder extension. Okay, and then you have teres major as well. Shoulder abductors. So all three portions of the deltoid are involved in shoulder abduction, with the middle deltoid being the most prominent. Okay, you also have supraspinatus, which is also a primary shoulder abductor. Okay, and then adductors. So we have pectoralis major, both portions of pectoralis major, the lats, teres major, and then again, in this new textbook, coracobrachialis and subscapularis are also considered shoulder adductors. Internal rotators, we have subscapularis, the lats, teres major. We also have anterior delt, that's not depicted here, but that is also an internal rotator. And then your external rotators. So same thing here, we already talked about posterior delt. Posterior delt is also an external rotator along with your infraspinatus and your teres minor.
What did you say wasn't pictured?
Posterior delt
Posterior.
for external rotation.
You said posterior for external rotation?
Posterior delt does shoulder external rotation. And then this one has your horizontal abductors and horizontal adductors. So for horizontal abduction, that's going to be performed by posterior deltoid, infraspinatus, and teres minor. And then horizontal adduction, anterior deltoid, and pectoralis major. Okay, so that brings us to your rotator cuff. Okay, you can remember your rotator cuff muscles by the acronym SITS. Okay, SITS. This stands for supraspinatus, infraspinatus, subscapularis, and what? Teres minor. Okay, make sure you don't confuse your minor and major. Teres minor is a part of the rotator cuff. Okay, so these muscles all work together to help stabilize the humeral head. Okay, it keeps it held in place within the glenoid cavity. Okay, that is its primary function, that is its job. Okay, you are going to see a lot of rotator cuff tears once you get into clinical practice. Okay, so we mentioned impingement the other day. Okay, impingement, subacromial bursitis. Your rotator cuff is also something that can get pinched underneath your acromion, between the acromion and the humeral head, because of its attachment points. Okay, so it's really easy for it to get frayed if you don't have good rotator cuff stabilization, rotator cuff strength. The humeral head will translate superiorly and pinch the rotator cuff between the humeral head and the acromion. So over time, that's going to wear down, it's going to lead to rotator cuff tears. All right, that brings us to nerves. We're going to do a lot with nerves today. Okay, so a plexus, just the term in general, is basically a network of nerves. Okay, and they combine in order to form the peripheral nerves. So in the upper extremity, we have the brachial plexus. Okay, now you guys have heard that term already, so we're going to really dive into what that is and what that means today. Okay, so brachial plexus is going to be formed by the anterior rami of the spinal nerves C5 through T1. Okay, so they branch and combine several different times in order to form our main 5 peripheral nerves. Okay, so these peripheral nerves are the ones that you guys are memorizing when it comes to your innervations for your different muscles. Okay, so this is basically where they're coming from. Okay, so within the brachial plexus, this is basically a drawing of the different nerves in the brachial plexus. Within the brachial plexus, we have 5 different sections. Okay, so these, where your dotted lines are the dividing lines between the sections. Up at the top, these are the names. Okay, so you have your roots. These are your nerve roots, where they're coming out between your different vertebrae. The trunks, you have a superior, a middle, and an inferior trunk. The divisions, you have anterior and posterior divisions. The cords, you have a lateral cord, posterior, and medial cord. And then the terminal nerves. Terminal nerves are your peripheral nerves. Okay, so these are the ones actually innervating your muscles. Okay, so that is the basic structure. Okay, before getting into the details, you have to understand the structure. Okay, so these are things that you need to have memorized. Okay. One important thing to note about your roots. So we have C5 through T1. Okay, and look how C5 is coming out above the C5 vertebrae. Okay, so that's where it exits, is above the level that corresponds with the same number. So right here, you have a C8 nerve root that comes out above T1, but we do not have a C8 vertebrae. Okay? Does that make sense? Okay, so again, C5 through T1, these are going to exit above the level of the vertebrae. Now, since we have this extra C8, after we get below the level of the cervical spine, now your nerve roots start to exit below the corresponding level. Okay, so T1 nerve root comes out below the T1 vertebrae. Okay? All right, so that's the important part about your roots. For your trunks, we have the superior trunk. The superior trunk is going to be made up of C5 and C6 nerve roots. Okay, so you can see how C5, C6 come together to form the superior trunk. The middle trunk is going to come from C7. And then the inferior trunk is going to come from C8 and T1. Okay, so that's how these things are formed. Okay, and then again, you can see how they've divided and now we're coming back together. So there's a little bit of crossover here to form your anterior and posterior divisions. something that you need to be able to draw. Okay, from memory, pull it out of nowhere. You should be able to do this without question. Okay? This, I would say this diagram here is the easiest way to draw it. I'll show you one more picture of one that looks like more of a handwritten drawing in a couple slides, but this is how I would start to practice. Okay? So if you want to see anatomically, this is what it looks like anatomically. Okay? So you can see it's a lot more squished together. It's a lot harder to differentiate all these different components. It's not going to be as clearly divided. But this is where it sits. It's right in your neck here and then goes underneath into your axilla. Okay. All right, so that is going to bring us to our first activity. Okay, so here is the handwritten drawing. Little caveat, we're going to practice drawing it in a little bit, so don't worry about that part now. But when you are drawing, this isn't an outdated picture that I just pulled off of the internet. So when you're filling in your nerve roots for this part, do it from your book. Okay, that's the numbers that we'll actually use. This is the same thing depending on what source you look at. Some things might be slightly different. You know, some books might say a nerve starts at C5, others say C6. So we're just going to go based off what's in our textbook. Okay, so first activity, you guys are going to make the brachial. Okay, so we're going to go through kind of each of these nerves just to make sure you know which ones we're talking about. Okay, so first we have the suprascapular nerve. That's this picture right here. Okay, this is coming off of nerve root C5, C6. So it's going to come off of the superior trunk and it is going to innervate the supraspinatus and infraspinatus. Okay, so that's what I mean by making sure that you approach these things in different ways. So you need to be able to talk about it from a muscular standpoint, know which nerve innervates which muscle, okay? But also you need to be able to break down each nerve individually, okay? On the far picture, we have the subscapular nerve. This also has nerve root C5, C6. This is going to come off of the posterior cord, and it will innervate subscapularis and teres major. Okay, we have the medial and lateral pectoral nerves. The medial pectoral nerve has nerve roots C8 through T1. It comes off of the medial cord, and it innervates pectoralis major. The lateral pectoral nerve. This has nerve roots C5 through C7. This one comes off of the lateral cord, and it innervates pectoralis major and minor. Okay, and in the far picture we have the axillary nerve. This has nerve roots C5, C6. This is going to be one of your peripheral nerves, and it will innervate the deltoid and the teres major. We also have something called the quadrilateral space. Okay, this is most relevant to your axillary nerve, which is why we're talking about it here. Okay, I don't think this is in your textbook. Somebody let me know if I'm wrong, but I don't think it is, so make sure you take notes on this part. Okay, this is an anatomical landmark that you will hear about as we move forward. Okay, this has its own pathology, own diagnosis that we'll talk again about in orthopedics. But basically, this is a space. You can see this little square that's formed in the back of the arm. This quadrilateral space has borders. Okay, so it is bordered by the teres minor superiorly, the long head of the triceps medially, the teres major inferiorly, and then the humerus laterally. Okay, so make sure you know those borders and what actually forms this space. Okay, so you can see again how it forms this little square, and then you can see the structures that run through the space. Okay, so your big ones being the axillary nerve, and then the posterior circumflex artery and vein. Okay, so all three of those things run directly through that little square that's made from your muscle and bone. Okay, so if you had any dysfunction in those muscles, if they were really tight, then that nerve and artery vein could all get compressed within that space, which could then cause symptoms. Okay, so that's why it's important. But for now, I just want you guys to know what this is from an anatomical standpoint and know your borders. Okay? Okay, we also have the long thoracic nerve. This has nerve roots C5 through C7. It comes directly off of your nerve roots. So this was the really long one, the first nerve that you guys twisted. And then this will innervate the serratus anterior. Thoracodorsal nerve. This has nerve roots C5 through C8. It comes off of the posterior cord and it innervates the lats. Okay, moving to musculocutaneous nerve. This has nerve roots C5 through C7. Again, this is one of your long peripheral nerves at the end. Okay, it's going to innervate corpobrachialis, biceps, and brachialis, which we haven't talked about, but we'll get to that next. And then your far picture is the radial nerve. So radial nerve has nerve roots C5 through T1. Again, this is one of your big peripheral nerves at the end. It innervates the triceps, anconeus, supinator, and then we'll get into, wrist and hand innervations later. Okay, so with that, now that you guys have kind of seen a little bit of a breakdown of what those nerves look like, I want you can either just straight draw the brachial plexus with the addition of the peripheral nerves now, or you can take your pipe cleaners, lay it over a sheet of paper, and then draw out from there and label the entire structure. So either way, whatever you feel like will work best for you, just start drawing. But just to head a little bit different of a direction, we've already talked about fourth couples several times at this point, so I don't feel like we need to spend a lot of time here. Somebody tell me what a fourth couple is.
Two or more muscles that work together to form an action.
What kind of action?
Rotation.
Okay, so we talked about it last week with your scapular muscles, okay, upper traps, serratus anterior, and the lower traps. And what action is that gonna facilitate? Upward rotation, good. And then for the shoulder, you have your deltoid and your rotator cuff. Okay, so those also form a fourth couple. And the important part of this is basically that it is just for stabilization. Okay, so again, your rotator cuff has to be working appropriately in order to basically preserve the integrity of your shoulder. Okay. And we related this earlier to impingement. Okay, so again, I know we've talked about this, but just to continue to explain how this works, if you don't have that stabilization from the rotator cuff, if it's not doing its job, deltoid is going to take over. Okay, that's going to be the much more dominant muscle group if your rotator cuff is not stabilizing appropriately. Okay, with this, again, you're going to get a superior translation of your humeral head, and that is going to pinch all of those structures between the humeral head and the acromion. Okay, that's going to include your rotator cuff, your subacromial bursa, your bicep tendon, the long head of the bicep tendon. All of those things are going to get pinched and it's going to become very painful. Okay, so you're going to get diagnosis of impingement a lot, but understand that impingement itself is not the actual issue. There's something underlying it that is actually causing that to happen. Okay, most typically rotator cuff weakness, tears, things like that. Okay, so again, it's going to be a lack of stability at the glenohumeral joint that will result in something like this happening.
How much of it is posture, alignment?
So a lot of it has to do with posture. Whether it's going to be like a chicken or the egg situation, right? Is it because you're sitting like this hunched over all day? Or is it because of the muscles that are actually being performed that are leading to those forces? Okay, so whenever you're working with these patients, posture is definitely going to be a component that you have to address, but you have to understand if it is just more habitual versus if there's an actual structural deficiency. So, is there another question? Let's see. Okay, last thing here, I just wanna touch on, again, we covered this in Bio 150 for those of you who are in person. But we also, and we talked about this a little bit in lab last week, we talked about reversal of muscle action. So your flashcards will have a lot of those type of indicators for certain muscles as well. So make sure you understand what that means and how it works for those muscles that are listed on the policy. Okay? So this is just an example, is crutch walking, because this is something that we're gonna see a lot of. So somebody tell me what reversal of muscle action is. Somebody say it confidently.
Insertion moves towards origin.
Are we sure?
Other way around. Origin moves towards insertion.
There
Okay.
we go. So your normal muscle contraction, insertion is gonna move toward the origin. Reversal of muscle action, origin is gonna move toward the insertion. So an example of that in real life is gonna be crutch walking. Okay, so you have all of these muscles where your hands are actually stabilized. So your insertion is not gonna move toward your origin, but you're going to get this movement, you're gonna facilitate this muscle action by the origin moving toward the insertion. Okay, so for example, your pec minor, we know, what are your actions for pec minor? I think I heard all of them. So in reversal of muscle action, it's actually gonna help to elevate the pelvis since it can't depress at the scapula. Okay, does that make sense? So it seems like a action that's occurring really far away, but you're basically just lifting your body up versus depressing your scapula down. Okay, so that's an example, and all of these muscles are gonna help to facilitate that action. Okay, basically again, pushing through your arms, trying to lift your body up slightly versus pulling the scapula down. Okay, so you're elevating your axial scapula. Okay, there's a little break from your nerves, now we're going right back to your nerves. Okay, so we're gonna do an activity here in a minute, but I wanna talk through like an example first, just to understand what we're looking for. Okay, so again, at this point, you know your origin, insertion, thirds, and actions, okay? Or not know them for this unit, but you know of them, hopefully. And for each nerve, you have to be able to say what would happen if that nerve was injured, okay? So based on your cards, based on that information you know, you have to be able to reverse it. Like I said earlier, you have to be able to look at it in different ways. So if you get a question that says, okay, your long thoracic nerve was severed, what actions is that going to affect? What muscles is that going to affect? So thinking about it in reverse rather than just your straight memorization of the cards. Okay? So, for example, if we start with the long thoracic nerve, okay? First, you want to be able to identify it on your brachial plexus, okay? Be able to locate it on your diagram or on your pipe cleaners for now. Tell me the nerve roots. So this one, we have C5 through C7. What muscle does it innervate? What does long thoracic nerve innervate? Serratus anterior. Okay, so if we had an injury to the long thoracic nerve, what would we expect to see? Okay, serratus anterior is likely going to be weak. If serratus anterior is weak, how is that going to present in your patient? So here it's going to be a winging scapula, because we know serratus anterior helps to hold the scapula against the ribcage. Okay, so that's how I want you guys to start thinking through these things versus just the straight memorization. Okay, so we're going to do a little bit of an activity. Okay, so for each nerve injury, we're going to break up into groups. Okay, you're going to again locate the nerve on your brachial plexus, be able to identify it, look at the nerve roots, list all of the muscles innervated by your nerve, and then describe if that nerve was injured, what is it going to look like? Is there going to be some type of deformity that you can physically see? And what actions are going to be weakened because of it? Okay, does that make sense? Okay, so you guys are going to do this, I don't care how, But in your groups, you are going to create one document, okay? You get one page, put as much information about this nerve as you can. And then as a class, you are going to combine this into one document. So then when you're going to study for your quizzes, for your tests, for your final, for your boards, you already have all this information about all these nerves in one place. Sound good? Okay, so let's go 8 groups of 4. I think we might have maybe 2 groups that have 3. Okay, you can break up however you want to. Go ahead and break, and then I'll assign each group a nerve. And again, pick one of your potential presidents to put it all together for you into one document and send it out.
Oh, I got this.
Sound good? And send it to me once it's done too. Deal?
Do we have to put the names of the group or?
It doesn't matter. Well, you know what, go ahead and do that because we ended up coming back to this activity in orthopedics. So, yeah, write your names on it so we can get back in those groups next summer. Okay. And then also, we had a couple groups that were able to find discrepancies in the textbook, okay?
Oh.
So like I said, depending on what reference text you use, your nerve roots might be different. And you can see that even within your own textbook too, okay? So, you guys can, the groups that did that, you guys can point them out to each other. And then, in general, just know you might have slight differentiation. We're gonna go with, I think, mostly what is in the actual chapters. Seems to be a little bit more consistent with other resources versus what was in like the nerve chapter of the book. Does that make sense? So keep with your flashcards, your typical origin, insertion, nerve connections. Those look like they have the most consistent nerve roots associated with them.
So not chapter 5.
Yeah, so it looks like there was a couple discrepancies in chapter 5. Okay. All right, so we are going to move on to elbow and forearm. Okay, this is a pretty easy chapter compared to the shoulder, so we're just going to kind of fly through this and then build upon it in lab as well. So as always, here's your objectives. Again, basically just reviewing your osteology, making sure you know your key bone landmarks, going through your osteopneumatics, your arthropneumatics for the muscles, make sure you know your organs, insertions, actions, and nerves, and then we'll go through a couple different pathologies today. Okay, so again, table of contents, bones, ligaments, joints, muscles, and nerves. So we're gonna start first more with your bony anatomy. Okay, so bony anatomy. Looking at this picture here, we have the distal humerus. Okay, so we're moving into the elbow joint. We already did proximal, moving now distally. So big things here are color coded. So right here, you have your olecranon fossa, your trochlea, your medial epicondyle, and your lateral epicondyle. Okay, and then in this image, your coronoid fossa is in the yellow, radial fossa here, capitulum, and trochlea again. Okay, and then there's a whole humerus on the other side. It's going to review some of your more proximal landmarks as well. Okay, we also have the proximal ulna and radius. Which bone is this? What? Ulna. This is your ulna, that's your radius. Okay, so looking at your ulna, this very top portion, we have your olecranon process. Okay, we have the trochlear notch. And then this little bottom outshoot is your coronoid process. Okay, those are your big things here. This one, you can kind of see the radial notch right here. It's also right here. That's going to be a concave surface. That's an indent here. And then at your radius, just a couple landmarks here. We have the radial head, the radial neck, and the radial tuberosity. Radial tuberosity is also called the bicipital tuberosity. Okay, why? What attaches there? What is it? Say it.
Biceps.
Biceps. Okay. At the elbow, we have something that is called the carrying angle. Okay. This is formed from the longitudinal axis of the humerus with the forearm. Okay. So this angle right here, you can see depicted right here. So humerus and then the forearm. So that angle that forms is called your carrying angle. Okay. This is typically larger in women than it is in men. That's because women typically have wider hips, so you have to carry your forearms further away. This angle occurs because if you look at the orientation of the humerus with the radius and ulna, this is not actually level. So the bottom of the humerus is not level. Okay? So your medial side, or the trochlea, sits lower than the lateral side, okay, or the capitulum. So it sits at an angle. Okay? So when you have your ulna and your radius moving, okay, if they're moving against the humerus, they're not truly going to move in a straight line. Okay? So even though it's a hinge joint, it's like a fake hinge joint. Okay? It's not perfectly straight. Okay? So again, straight line down the humerus, straight line down the forearm. That intersection is your carrying angle.
Or hand holding angle.
Hand holding angle. So here are your norms. So males, you typically have about 5 degrees. Females, 10 to 15 degrees. Those are your norms for the carrying angle. Okay. So now we have abnormal carrying angle and what that looks like. Okay. So on this side, we have cubital varus. This is basically an inward angling of the forearm. Okay. This angle typically occurs when the LCL is weak. Okay, your lateral collateral ligament that sits on the outside of the elbow. Okay, so it's weak, it's overly lengthened, it's stretched, however you want to look at it, so the elbow is able to fall inward. The lateral collateral ligament, LCL. Okay, this is also called a gun stick deformity.
What?
Gun stick. G-U-N, gun stick. Okay, this picture over here is called cubital valgus. Okay, valgus, you have an outward angling of the forearm. This is likely going to be due to weakness or an overstretch of the medial collateral ligament of the elbow, the MCL. Okay, this one is going to be much more common, the cubital valgus, as compared to cubital varus. Okay, so moving on to your joints. Okay, we have 4 major joints that we're going to talk about when it comes to elbow. Okay, at the elbow itself, the elbow is actually made of 3 joints. Okay, so we have the humeral-ulnar joint, humeroradial, and the proximal radial-ulnar joint. So all 3 of those are located at the elbow. So starting first with our humeral-ulnar joint, this is going to be the articulation right here of the trochlea of the humerus, that's this part, with the trochlear notch of the ulna. Okay, so articulation between the humerus and the ulna. Okay, this, when somebody talks about the elbow, this is the joint that they're talking about. Okay, humeral ulna is the elbow. Okay, this is your true elbow joint. This is a uniaxial hinge joint with 1 degree of freedom. Okay, what does that mean?
One plane or one axis.
1 plane, 1 axis. So what motions occur here? Elbow flexion, elbow extension. Okay, for each of these, I've listed out your open pack position, closed pack position, and your capsular pattern. Okay, so for your humeral ulnar joint, open pack is going to be 70 degrees of elbow flexion, 10 degrees of supination. Closed packed is going to be full extension and full supination. And then your capsular pattern, flexion, will be more limited than extension. Okay. All right, next we have the radiocapitellar joint. Okay, this is also called the humeroradial joint. Okay, but radiocapitellar is going to be the more specific term. Okay, so this is your articulation between the capitulum of the humerus and the radial head of the radius. Okay, your head always needs a cap. That's how you can remember it. Radial head, capitulum. Head needs a cap. radiocapitellar joint. This is a synovial plane joint. Okay, so you will get a glide here with flexion extension. We'll talk about in a minute. Okay, so again, open pack, closed pack, capsular pattern. These are different at each one of these joints. Okay, so your open pack position for radiocapitellar joint is full extension, full supination. Your closed pack position is 90 degrees of elbow flexion and 5 degrees of supination. And then your capsular pattern, flexion will be more limited than extension, more limited than supination, which is more limited than pronation. Okay, so you have to remember that order. Okay, next we have your proximal radial ulnar joint. Okay, so we have two radial ulnar joints. There is a proximal and a distal. Proximal one is up close to the elbow, the distal is down by the wrist, but they work together. Okay, so these are uniaxial pivot joints. So your proximal radial ulnar joint is going to involve the articulation of the head of the radius and the radial notch of the ulna. Okay, so head of the radius, radial notch of the ulna. Okay, I don't think I have a distal one. So your distal we'll talk about more in the wrist, but your distal radial ulnar joint is going to be the articulation of the head of the ulna and the ulna notch of the radius. Again, that is present at the wrist. Okay, so this is important during pronation and supination. Okay, during these actions, the radius moves over the ulna. So the ulna does not move, just your radius moves. Twist over top of the ulna. Okay, but functionally, your proximal and your distal radial ulnar joints are going to work together in order to perform the movements of pronation and supination. Okay, so what plane, what axis is that going to occur in?
It's horizontal with the axis, vertical axis.
Exactly, so your transverse plane, vertical axis. So for proximal radial ulnar joint, open pack position, 70 degrees of flexion, 35 degrees of supination. Closed packed, 5 degrees of supination. Capsular pattern, pronation and supination will be equally limited. Okay. All right, osteokinematics, we already said elbow flexion and extension are going to occur here. Okay, so here are your norms. Normal degrees and your normal end fields. So for elbow flexion, your norm is 150 degrees of flexion and the expected end feel is soft. Okay, why is it soft? Exactly. Correct, big guns. Extension, your norm is 0 degrees, and that is going to be a hard end feel, okay, because of that articulation with the electron on it. Okay, supination, pronation, these are easy to remember because the norms for both of them are 80 degrees, and they are both firm end feels. Okay. All right, arthrokinematics. So we're going to focus first on your flexion extension. Okay, so your distal humerus is going to be your convex surfaces, and then your proximal radius and ulna are going to be your concave surfaces. Okay, so if I'm moving in open chain, which way am I moving? Convex on concave or concave on convex? Concave on convex. Okay, which means what? Same direction as the distal end. Exactly, as the distal end of the moving bone. Okay, so that means if I'm moving in open chain and I'm going into elbow flexion, my glide is going to occur anterior. Okay, versus if I'm moving into extension, it would occur posterior. Does that make sense? And I get a couple more nods, yes or no, so I know where we're at. I'm just gonna say it again, not that much. Okay, so we have The distal end of the humerus is convex. The proximal ends of the radius and ulna are concave. So in open chain, I am moving concave on convex, which means my glide occurs in the same direction as compared to the distal end of my moving bone. Okay, if I'm moving into elbow flexion, the distal end of my moving bone is moving
Yes.
anteriorly.
Yes.
So that means my glide is occurring anteriorly. If I'm moving into extension, the distal end of my forearm is moving posteriorly, so my glide is going to occur posteriorly. Good? All right, got a few more head nods. So, something to study and digest. If you have further questions on it, come by. Okay, well, just to make it more complicated, we also have pronation and supination. So let's do, we're gonna do proximal radial ulnar joint first, and then we'll do distal. Even though these are working together to perform the same actions, do not clump them together in terms of their arthrokinematics. Okay, at the end of the day, they are still two different joints doing two different things. Okay, so at the proximal radial ulnar joint, your radial head is convex, and the radial notch is concave, meaning in open chain movement, you have convex on concave. Okay? Which means what? It's gonna occur in opposite directions. Okay? So if I am moving into pronation, I'm gonna have a posterior glide. If I'm moving into supination, I'm going to have an anterior glide. Okay, we're moving opposite. In addition, when you're moving in pronation, supination, at the actual articulation between the radial head and the capitulum of the distal humerus, you're also getting a spin that's occurring there. Okay, different from our regular elbow joint. Okay, at the distal radial ulnar joint, this is different than proximal. Okay, at the distal joint, the radius is concave, the ulna is convex. So here we have concave on convex, so you're getting the same direction. Okay, so for pronation, you're getting an anterior glide. For supination, you're getting a posterior glide. Okay, so again, something to go back, make sure you think through it, make sure you understand it. All right, moving on to ligaments. Okay, these ones are a lot easier than the shoulder. There's only 3 of them that we're gonna really talk through. Okay, so first we have the lateral collateral ligament. Okay, so this is going to attach proximally on the lateral epicondyle of the humerus, and then distally on the annular ligament, which we'll talk through in a minute, as well as just the lateral side of the ulna. Okay. The job of this ligament is to restrict varus stress. On the other side, we have the medial collateral ligament. Okay, this one is more triangular. You can see in this picture right here, it's this entire area. Okay, this is going to attach to the medial epicondyle, and it will run more obliquely right here toward the coronoid process of the ulna. Okay, that's this part right here. So since it's on the medial side, this is going to restrict valgus stress of the elbow. Okay, so it's right here, it's restricting forearm motion this way. That's a valgus stress, elbow coming in, forearm going out. Okay. This is going to be the much more commonly injured ligament, especially when it comes to baseball players. Okay, any overhead athlete, you'll see a lot of injury here. Okay, medial, this is also called the ulnar collateral ligament. Those terms are used synonymously. For lateral collateral ligament, you'll also see it as the radial collateral ligament. So again, same terms. right here, sitting on top, over top of the radial head, we have the annular ligament. Okay? So this basically attaches to the anteriorly and posteriorly to the radial notch of the ulna, and it just literally encompasses the entire head of the ulna, or of the radius, I'm sorry. It holds the radius against the ulna. Okay? This ligament is very, it's not commonly torn, but it's common for the radius to be dislocated from this ligament. Okay? So especially, as you can see in this image here, when, you know, your parents, you're holding your kids by their hands and swinging them, okay? That can pull the radius out from underneath the radial head. So you get, it will pull the radius out from underneath the annular ligament. So you'll get a radial head dislocation.
Is that Nurse Smith's elbow?
Yes. Okay. So any type of distraction, force, or pull on a child's hands, you typically see this thing. Okay. And we do, I think we have a slide on Nurse Smith's elbow for a while. Okay, we also have the joint capsule. Okay, this basically encompasses the entirety of the elbow. It attaches around those proximal ends of the ulna and the radius. This is going to be strengthened anteriorly by your ligaments, posteriorly as well. The annular ligament will contribute to this capsule as well, and then your collateral ligaments will reinforce the medial and lateral sides of the capsule. Okay, so during elbow flexion, okay, you can see the capsule will become loose anteriorly and it will become taut posteriorly. Versus extension, it's going to be the exact opposite, so it will be more loose posteriorly and taut anteriorly. Okay, we also have an interosseous membrane between your radius and your ulna. Okay, this is basically just a broad, flat membrane. It sits right in between those bones for the majority of the length of the bones. Okay, its main job is basically to keep these bones from separating. So it just keeps these bones held together. Okay, muscles, same goes as always. Make sure you know your origins, insertions, actions, and nerves. We're not going to talk through them, but we have them listed out here for you. Okay, so elbow flexors, we have your biceps, brachioradialis, and your brachialis. Okay. For these ones, make sure you know which one is going to be your primary elbow flexor in what position of supination or pronation. Okay, so biceps, for example, we know biceps is an elbow flexor along with a supinator. So when you do just your standard bicep curl, your forearm is in supination, bicep is going to be most active. Okay, versus brachialis, if I want to inhibit my bicep, I'm going to go into pronation. Okay, so if I do a pronated curl, that is going to target brachialis more specifically. Versus brachioradialis, you're going to do that in neutral. Okay, it can supinate or pronate from that neutral position. So if you do a bicep curl with your forearm in neutral, that is going to more specifically target brachioradialis.
Beer drinker.
Huh?
It's the beer drinker muscle.
The beer drinker muscle, yes, very important. Okay, elbow extensors, you have triceps and inconius. Tricep is obviously going to be the most dominant elbow extensor, and conius is just going to assist. Okay. All right, your pronators, you have pronator teres, pronator quadratus. Okay, so similar to kind of what we were talking about at the level of the joints, these two muscles work together to perform pronation. Okay. And then lastly, we have supinator right here. Okay, along with bicep. We know bicep is a supinator as well, so make sure you clump that in with your supinator. Okay. Right here we have what's called the cubital fossa. Okay, this is basically a triangular depression on the anterior elbow. So similar to our quadrilateral space, you want to make sure you know the borders here. Okay, so it's going to be bordered laterally by brachioradialis, medially by pronator teres, superiorly you have this imaginary line basically between your medial and lateral epicondyles. Okay? That line is going to correlate with where your skin crease is at your elbow. Okay? The floor of this triangle is going to be formed by brachialis and supinator muscles. Okay? And then you have a lot of structures that fall within this space. Okay? Now I'm going to list them from lateral to medial. Okay? So you have the bicep tendon, the brachial artery, and the median nerve. Okay? So make sure you know where this artery is, because I think you guys are doing blood pressure or something with Christy. So you're probably going to be palpating that. Okay? So when you do your blood pressure, that's where you're going to place your stethoscope. Okay? Over top of the brachial artery. Okay? Just a little bit on nerves. I know we've done a lot of that today. So again, now that we're getting more peripheral, this is where your peripheral nerves from your brachial plexus are coming in. Okay? So the three big ones that we have in this area here include your median nerve, your radial nerve, and your musculocutaneous nerve. Okay? So this is the whole course of your median nerve. So it has all of your innervations. Here's your brachial plexus up here, and here's how it courses down the entire arm. Okay? So for the muscles that we showed today, this is going to innervate your pronator teres and pronator quadratus. Okay? On this side, you guys are really focused on learning the muscle innervations at this point. But also realize that a lot of these nerves also have a sensory component. Okay? These types of diagrams show the sensory component for the nerves. So you should be able to, point to someone else's arm and say, oh, okay, what nerve innervates the skin on this section? What gives this area sensation? So right here in this blue, you know, okay, this sensation is coming from the axillary nerve. Okay? So especially as you get into more of the peripheral nerves, you're going to see that more specifically. Okay? So if we look here at the radial nerve, okay, here's the whole course of your radial nerve. Here's your brachial plexus, how it courses down the arm, all of the muscles it innervates. Okay, it has a lot of different innervations. And then over here, you can see nicely color-coded on the hand. This is the dorsum of the hand. Your median nerve is going to get the tips of these fingers. The radial nerve gets this whole part of the hand. And then ulnar nerve is going to get your pinky and half of the ring finger. Okay? So not only do you guys need to understand it from a muscle innervation standpoint and what actions it's going to contribute to, but also where it's giving its sensation. Okay. We also have the musculocutaneous nerve. Okay, so this is going to be your big innervator for the biceps and brachialis. Okay, so same thing here. You can see it from the brachial plexus, where it's coming off, how it's coursing down the arm, and then your sensory distribution here. Alright, so just a few different pathologies for the elbow that we're going to start to talk about. Again, we'll get more in detail with these as you guys progress through the program, but just to help start making some of this terminology familiar to you, I want to go over a few of these. So lateral epicondylitis, this is a really common one that you guys will see. This is also called tennis elbow. Okay, it's a very common overuse condition that is going to affect the common extensor tendons of the forearm. Okay, so at the elbow, you have all of these muscles that try to come in and insert on a tiny part of the epicondyle. So because of that, instead of all of the muscles originating or inserting at that bone, they form one common tendon, and that common tendon is what actually attaches to the bone. Okay? So when I say common extensor tendon, this is all of your wrist extensors originating at the same place. Okay? So that tendon gets aggravated, it gets inflamed, it gets irritated, and that's where the pain is going to come from. Okay? The most common muscle affected in lateral epicondylitis is the extensor carpi radialis brevis. Okay, and we'll go over those muscles next week. Okay, but this is going to be very common in racket sports, anything that contributes to excessive or repetitive wrist extension. Okay, so even like you guys typing on the computers, things like that can cause this as well. Okay. On the other side, we have medial epicondylitis. Okay, this is going to be more bulbous elbow. So same concept, but we're on the other side of the elbow. So it's going to be inflammation, irritation of the common flexor tendon. Okay, so anything that does wrist flexion, that starts at the medial epicondyle. Okay, so any type of repetitive wrist flexion activities will contribute to this pathology. Okay, we also have little league elbow. This is going to typically be associated with baseball, as indicated by the name, okay, caused by repetitive throwing. You're going to see this in young baseball players, mostly that have not yet reached skeletal maturity. Okay, so we know throwing is going to place a lot of valgus stress at the elbow, and it's going to cause a medial distraction at the actual joint. Okay, so you're going to get an inflammation of the apophysis or the growth plate that is present at the medial epicondyle. So it's going to cause a lot of medial epicondyle pain. Olecranon bursitis. Okay, so you have a bursa, the olecranon bursa, that sits in between the olecranon and the triceps. Okay, we know bursa are going to be present in areas of excess friction. So the purpose of that bursa is to protect the tendon of the triceps. Okay, so this can become swollen, red, irritated, very painful, typically with overused or tight triceps, along with prolonged pressure. Okay, so you see in this image here, if you guys are sitting with your hand on your head sitting on your hands, you're putting pressure right over top of the elbow where that bursa is. So anything like that can cause a bursitis to occur. Okay, nursemaid's elbow, we basically already talked about this one, but again, this is going to be any type of traction force where the radial head dislocates from the annular ligament. And then last one here, we have supracondylar fractures. This is going to be one of the most common fractures that you see in kids, and it is caused by Fuchs injuries. What does Fuchs stand for? Fall on an outstretched hand. Okay, so here, the distal end of the humerus will fracture just above the condyle. So you can see that in this picture right here. Okay, the greatest danger with this type of injury is the placement of that brachial artery. Okay, so we saw where that sits earlier, and you can see where the fracture site is. It's going to be very close to that artery. Okay, so that can cause compression on the artery, and that can lead to something called a Volkmann's contraction. Okay, where you're actually going to get like a really severe necrosis of the forearm muscles. Okay, so again, we'll talk more about this stuff in a couple semesters, but I just want you to start becoming familiar with this terminology. Okay? All right, do you guys have any questions? Okay, so listen real quick before you back up, let me finish. For your pipe cleaners, if this is something that you are going to use as a study tool, then please keep it. If you are going to leave here and throw it in the trash can, please leave it here instead. Sound good?
Yes.
Okay, remember lab group today, we're gonna start